Ladies and gentlemen, welcome to our 6th webinar session, COVID-19 Vaccines, Specially Targeted Education Program, Building COVID-19 Vaccine Confidence by Educating the Educators. This program is being run in collaboration with the SickKids Learning Institute, the Black Creek Community Health Center, the Scarborough Health Network Vaxfat Clinic, and the Black Physicians Association of Ontario. This afternoon, we are privileged to have presenting for us Dr. Michelle Barton-Forbes, who will be speaking to us on common questions that parents want answered. We will go to the acknowledgement, and then I will introduce Dr. Barton-Forbes. Please remember, this will be a recorded session. Next slide, please. Yes, pardon our technical hitches to be resolved in a moment. Thank you. Thank you. Before we begin, we would like to acknowledge the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and the Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit Valley. Today, Toronto is home to Indigenous peoples from across Turtle Island, and SickKids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples. And we are grateful for the opportunity to share this land in caring for children and their families. So we are very privileged to welcome Dr. Michelle Forbes, who is an associate professor at the Western University and is the division chief of infectious diseases at the Children's Hospital London Health Sciences. She sits on several national and regional committees involved in developing guidelines for the management and prevention of COVID-19 in Canadian children. In a clinical role, she's actively involved in the management and prevention of COVID-19 in children in the Southwestern Ontario region through special initiatives like the region's only pediatric COVID-19 virtual clinic and the special vaccine clinic that supports parents and children in decision-making around COVID-19 vaccine. As an associate scientist in the Lawson Child Health Research Institute, she's actively involved in multiple multi-center studies, including studies on COVID-19 and natural and vaccine immune responses in marginalized populations. She has won local and international awards in teaching and research and has several publications in the area of infections in children. So this afternoon, she'll be addressing the common questions that parents want answered. Dr. Barton-Forbes, thanks for being our guest. Please, over to you.
Thank you, everybody. Thank you, Isaac. So today's talk, I would like to focus on the questions related that are related to the vaccine in a sense, in particular, the impact of COVID-19 on children, because that looks at the benefit of the vaccines. And then of course, then the safety issues is another big reason. Okay, all right. As you know, this pandemic, which has stretched over now 2 years. We never dreamt that it would go on for this length of time, and it now is beginning to look very bleak as to when it will end. Multiple things have happened along the way, but I think the light at the end of the tunnel has been the development of vaccines, and in particular for us as pediatricians, the development of vaccines now approved for use in children. So the vaccines were approved, as you know, for older children earlier on in the year, but most recently in November 2021, we now have vaccines available to us. Of course, we're caught in the middle of a divide. The whole COVID-19 vaccine story has divided families, friends, countries, you name it. There is a divide between those who see the vaccine as needed and buy into it, and those who are either hesitant or totally refusing. And it is even that much more challenging for, while it is okay when it is your decision, your individual decision, what becomes challenging is when it now comes into the sphere of parents and their decision making, because they are now asked to make a decision in the best interest of their child. And that is the dilemma. So we get to the whole concept of vaccine hesitancy. And this vaccine hesitancy is not new to pediatricians. We've struggled with vaccine hesitancy over years, because as pediatricians, we have to deal with selling the concept of common childhood vaccines to parents. And of course, giving vaccines to children when in the most part they're healthy, the parents, their biggest decision is, should we give the vaccine to our healthy child who's not manifesting any concerns for serious infections? How do we know that it will not harm them? Somehow, this vaccine dilemma and vaccine hesitancy has escalated in the era of COVID-19. So I think even now more so, parents are finding it challenging to make a decision as it relates to COVID-19 vaccines. And I think it's unfortunate because part of it is as a result of the mixed messages that parents have received over the period of the pandemic. And by that, I mean, not to any fault of ours, but the whole knowledge of COVID-19 and the change in variants have meant that the story has changed multiple times through the 2-year period. And you now have, if you had parents who were skeptical of science, they're now even much more skeptical of science, and they find themselves in a dilemma. It has not helped, of course, that social media has blasted issues with misinformation out of proportion, far more than what we were accustomed to as pediatricians with the run-of-the-mill common childhood vaccine preventable diseases. So COVID-19 and COVID-19 vaccines create quite a dilemma in terms of decision-making for parents. And it's even that much more for parents in the sense that at the beginning of the pandemic, we were told that children were not affected by COVID-19. And that was the message that was sold right throughout. And it's not, part of it is, I think, at the beginning, we were rationalizing testing to the elderly, and when test capacity was not there. Now we have better test capacity. So children are being tested, but at the same time, the vaccine variant, the COVID-19, the SARS-CoV-2 has emerged with various variants with increasing transmissibility and better spread in children. And then, of course, the change in vaccine epidemiology, in the sense that now that we have vaccines and a lot of the adult population is now immunized, it's not surprising that we're now seeing more and more children infected. So this change over time has contributed significantly to parents' vaccine hesitancy. And I think we as pediatricians, we need to be able to help them navigate this confusing path and come to a comfort zone in making a decision. And I think the first question is, we would have to establish this with the parents, because they're questioning, does it really affect our children and how? So that's the first question, because answering this question will answer the question, are there benefits in vaccinating the child? So we know that in the latter part, in this fourth wave, come September, August, September, we started seeing much more children affected. And now we recognize that children less than 12 years of age account for 20% of cases. This graph shows you that we have gotten to the point where now the fourth wave shows that the majority of individuals being affected are in the 0 to 11-year age group. So there's no question, it affects children. And these stats further show that, you know, we have children being affected so far. From this is still dated, it's what's available online, but it's as of June, as up to June 2021, 70,000, over 70,000 of our cases were in the pediatric age group. All right, so if it's so, okay, it does affect children, but how bad is the impact? So when we look at the impact on children, we really need to understand that the impact of COVID-19 is beyond just morbidity and mortality. And so if we look first of all at morbidity and mortality, because those are the measures that we usually use for vaccine preventable diseases, we usually try to establish, okay, does it cause significant illness and can it cause death? So, first of all, how severe is SARS-CoV-2 infection in most children? So the truth is that most children with SARS-CoV-2 infection have little or no symptoms, and the symptoms generally resolve quickly. However, even though the vast majority of children will not get very sick from SARS-CoV-2, or at least not get sick acutely from SARS-CoV-2, we do know that some get very sick. So this slide is taken from the CPS grand rounds recently, and this summarizes the age groups affected and the percentage of hospitalization and ICU admission. So we see that by far, not many children get admitted. And if they do get admitted, quite up to 5% are in the less than 1 year age group. But when they get admitted, if you do the math, you will see that once they get admitted, up to 20% of those admitted will end up in ICU. Fortunately, death is rare. Okay, so what other morbidity can COVID-19 cause? So COVID-19, your child, the child may end up getting the infection, and for the most part, 80, 90% of them will get better without any problems. Okay. But in the next 2 to 6 weeks after getting the infection, we are recognizing that a small subset of children may end up with this inflammation in multiple organs that make them quite sick. And this illness is usually requires hospitalization. So what percentage are we talking about? We don't actually have the rates across Canada tight number on the rates across Canada, but when we look at our US partners, they are describing rates of anywhere between 0.5 to 3% of children who get COVID can go on to have MISC. And I should make the point that it doesn't matter whether the child was symptomatic or asymptomatic, that your child who didn't seem to have any problems could then have problems, but thankfully it is still rare. When it does happen, however, 1% of the US cases have died. Here in Canada, we've had no reported deaths among the reported cases in Canada. We still need some more data on this. Here, the next thing to think about is this condition called long COVID, where persons who have COVID go on having symptoms beyond 3 months from onset of illness. And this is well described in adults, where up to 20% of adults end up with long COVID. It's not as clear in children, and the data is evolving. So rates may range from, some papers say 2% to 10%, some even say higher. But the main symptoms that children seem to have, so it's a whole constellation of symptoms that you can have, but the main symptoms described in some of the cohorts are headache, fatigue, and loss of smell. But of course, it can be other more distressing symptoms like tinnitus or insomnia. Apart from the morbidity and the mortality that we've highlighted, there are several negative impacts that we have now come to appreciate that our children are facing as a result of this COVID-19 pandemic. And it's the impact on their mental health, their emotional health, their social interactions, their educational health, even things like the well baby care, like immunizations, regular immunizations, have fallen behind because of virtual care during lockdown, etc. And then, of course, there's been delayed medical care, delayed diagnosis of malignant conditions and other time-sensitive conditions. So as well, our children have had to battle the loss of loved ones or the limited contact with loved ones like their grandparents. And of course, unfortunately, especially in the developing world, there's been an increased toll as it relates to orphans, parental loss, and therefore orphans. And then, of course, there's financial impact on the family. So I think if you look at the whole picture, there is benefit there is definitely benefit because we have shown that it impacts children. Now, the next question is, do we know which children will get very sick? So whenever you have a vaccine, as you try to make the decision, you're trying to make the decision between, the decision is between the benefits and the harms. And you want to make a decision for, you approve something when the benefits outweigh the harm. And this is what we have to, provide the parents with as they try to make a decision. They need to be able in their own mind to weigh whether the benefits outweigh the risks. And so we've spoken about benefits in general, but there are some children who may even have higher benefit from getting the vaccine. And who are these children? And at this, we also need to tell the parents, because if parents are hesitant, you will find that if they know that their children are at a higher risk of severe disease, then it may help them to feel more at peace in making a decision for the vaccine. So what do we know about which children get very sick? So the Canadian Pediatric Society surveillance group project has published on their experience across the country. And this was published in September 2021. And in their report, they pointed out any children with comorbidities, but some of them included neurological conditions, chronic lung disease, excluding asthma. Those were some of the ones they highlighted. And of course, outside of chronic comorbidity, children who have underlying obesity were identified to be at risk. In our picnic group, we this was accepted or included in the CDC science update in November 2021. And this is our group's work across Canada, a multi-center study, also including the Middle East and Costa Rica. But even when you pull out the Canadian subset, this was what we were finding. So obesity, children with anemia or hemoglobinopathies, neurological disorders, and the children who were otherwise healthy who presented with co-infections like bacterial or viral co-infections were also more likely to have a severe course. And of course, if they had underlying a diagnosis of MISC, they also had severe outcome. So in concluding the question, are there benefits? I would say yes, there are benefits. And the benefits are in preventing the severe disease, in reducing school and community transmission, and in controlling the disease. Remember, bearing in mind, I like to use this analogy. If you had two rooms with one room with 6 people and another room with 100 people, and you are playing a Chinese telephone, and they whisper the same message at the beginning, at the end of the 6 versus at the end of the 100, how distorted do you think the message would be? Clearly, the message would be much more distorted in the room of 100. Therefore, if we don't get moving with vaccinating as much of our population, we will have a significant number of bodies that still remain susceptible to the virus. And once the virus is able to find susceptible hosts to continue its propagation, then we can have mutations. So another spin-off that we should share with our parents is that they contribute to the big picture of population dynamics, and therefore probably reducing the chance of ongoing mutations. And then, of course, lastly, we emphasize to the parents who have children with chronic comorbidities, obesity, or immunodeficiency underlying hemoglobinopathies, or children who are living in communities that are overcrowded with high levels of virus activity, that those are just the children that need to be prioritized. If it is that the parent is extremely hesitant, if they have these conditions, they may need to think again. Okay. All right. So we have vaccines, and we recently had the 5 to 11 approved. So I know in previous sessions, we've gone through much of the vaccine stuff again, but this is a common question that people are asking. They're asking, are the vaccines for the older child similar to the vaccines for the younger? In other words, can we extrapolate the information that we have in the older child to the younger child? And so the first thing I want to say is that the formulations are slightly different. Even though the vaccine in principle is the same, the dosing is different. And there might be slightly minor changes in the constituents, but the key thing is that the dose is different. And so a lower dose is used for the child who is 5 to 11 years old, and that's a third the dose of the dose used in the older child. All right, so that's an easy answer to them. Whether you can extrapolate the information, I think the information in terms of efficacy is pretty similar across the board. Both sets of vaccines are quite efficacious. In other words, do they work? Yes. What we know is that when they compared the antibody responses in the 5 to 11 versus the older child, it was not inferior. In other words, equivalent. And when we look at actual efficacy data, we see that the performance of the vaccine in children 5 to 11 is comparable with the adult performance. Adult performance is like around about 94%. The adolescent performance is 100%. And the 5 to 11-year-old is roughly 91%. So we're talking about really efficacious vaccines that achieve over 90% protection against the usual variants and Delta variant. If we have time at the end, we'll mention the emerging variant. So what are the common side effects is another question they ask. They are concerned about safety. Remembering that side effects are the milder type symptoms that are with every vaccine, we have some amount of side effects versus adverse effects, which are rare, serious effects that we will mention after this. So when we say what are the common side effects, we're really looking at the topical, the local side effects. So for most part, this vaccine is known to cause soreness at the arm, regardless of the age. And what we see in the 5 to 11 is similar. Up to 71% of the children who got were 5 to 11 had local side effects. The other side effects, which are a bit more systemic, the fever, the headache, the muscle pain, is actually slightly less in the 5 to 11-year-old group. So what about serious harm? That's another big question parents ask, because they're convinced now that there's benefit, but they now need to know if there's harm. And what we know is that in the vaccine trial, for the children 5 to 11, no events of myocarditis were noted. I will be cautious to say that we can only comment on events that are less, we can't comment on events that are more or less frequent than 1 in 1,000. And so over time, as we roll out the vaccine, just like what happened with the adolescents, as we roll out the vaccine, we're better able to tease out the extremely rare events. But in terms of the 5 to 11, can myocarditis, they keep asking, will myocarditis happen? So I think we first need to establish the experience in the older child when we're talking to the parents. We need to say, yes, myocarditis was seen in the older population, but what we do know is that the events were not severe, and the majority of children responded to just mild or no therapy. And so, yes, the event occurs, but you want to know that the event still has a good outcome. And that's what we can say. We can also emphasize the fact that it is a very rare adverse event, not happening in more than 1 in 10,000. And we can tell them a little bit about who to expect it in and what to watch for. The most important thing is that if we educate the parents as to what to watch for, that they can come in when those symptoms are occurring, then we can manage whatever needs to be managed in these patients. in terms of the 5 to 11 year group, that group time will have to tell, but we anticipate, we can tell the parents that we anticipate that the chances of myocarditis at best may be lower than the older, but at worst should be no worse than the adolescents. And so at best we say, because the dose is lower, because the children are not yet pubertal, and we think that it may be a hormonal link, there may be a hormonal link, and because we've delayed the second dose in Canada to 2 months, stretched it out as compared to the States, we feel that it will be less so. Okay, so then at the end of your discussion, you can now present the parents with a tally of the benefits versus the risks, and allow them to be able to better answer the questions that most bother them. And those are the main questions. Now, other questions arise, and the other questions arise related to, should my child get the vaccine if they have already gotten the disease? And what you need to be able to, what we need to be able to do is to reassure the parents that actually getting the disease and getting following that with the vaccine will only benefit the child with a more boosted response, and that boosted response will ensure probably a better response to future exposures as it relates to new variants, provided the new variants don't evade the vaccine immunity. All right, another common question they ask has to do with the dosing of the vaccine. If my child is 11 and got the first dose at 10 micrograms and turns up 2 months later and is now 12 years old, should my child finish the dose with the same dose that they started? And of course, the answer is it's age dependent. It really, the cutoff is age by birthday. And we don't adjust dose by weight of child or by previous dose that the child got. Okay, all right. And so the last thing that I think is topical to bring up is, what about the new variants? So Omicron, the Omicron variant, as we're still gathering data about this, but I think what's the big question that people are asking is, what will this do to vaccine protection? And we don't have all the data available yet. As you know, the Omicron has multiple mutations and has been described in multiple countries now, even in Canada. I think what we need to recognize is that we have some reassuring news that has just come out, that giving a third dose of the vaccine improves the vaccine efficacy. So after 2 doses, it appears that there's a 25% reduction in vaccine protection. And then we are now gathering data that suggests that a third dose may actually better protect us against the Omicron variant. I'm going to pause here now because Dr. Allen is here, and I think I may be overstepping my time.
No, Michelle, thank you so much. I'm sorry I had to a last minute event that I had to address. So maybe I'll ask my twin brother, Isaac, to take us through.
Well, Michelle, did you stop abruptly? I think you can continue.
Okay.
I think you have more in you to give.
The time. Yeah. So this basically shows you how the Omicron compares with the Delta, and we're talking about several more mutations than what we saw in the Delta variant. And as you know, the spike protein is the site that the vaccine targets, and our concern as scientists always has to do with a virus that has multiple mutations of the spike protein, because it gives us anxiety as to whether our vaccine protection will fall off. And this is what we need to closely watch. The other thing with emerging variants is the whole question of transmissibility, 1, and 2, disease severity. And it's still evolving, but there is a concern that this variant may actually be more associated with spread and transmissibility. In terms of the severity, I don't think we have that information conclusive yet, but definitely it seems to be we're wondering if these new surges in numbers are related to the emergence of the Omicron variant. So in terms of our parents, back to our parents who are asking questions need to be provided with resources, and there are several resources available through the AAP and CDC, but this resource might be useful for practitioners. The CPS guideline is more geared to practitioners as you educate your parents. I find this very useful to remind parents about when they're trying to make decisions. I ask, do you know that every time you jump into a car, there's a 1% chance that you could end up in a crash, but do you still go for a drive? And when I ask that question, they always end up saying, I never thought of that. You're right. I said, and yes, and the harm from the vaccine that we're talking about in terms of adverse effects as it relates to things like myocarditis, we're talking about 1 in 10,000. So, oh, okay, all right, I didn't realize. I think it's not as bad as I thought. So this question always brings things back into perspective. Thank you.
Thank you very much. We are now moving to the Q&A session, and there's one already posted. So how will you respond to a parent who is concerned that in comparison with the adult studies or the adolescents, the numbers that were enrolled in the 5 to 11 clinical trials was much smaller and not as robust? What will you say? And that may explain why no case of myocarditis was seen.
So even with the adolescent studies, myocarditis was not seen. Remember, the rate of incidence of myocarditis is 70 per million in boys and 10 per million in girls. So roughly speaking, in boys, around about 1 in 10,000. So you would not be able to enroll enough patients in a study to be able to be conclusive about rare side effects. We know that. So I think the key with the 5 to 11 year study was to, 1, establish that you did at the 10 microgram level, you were having antibody responses that were non-inferior. That's 1. And 2, to establish what the rate of common side effects are. And 3, look at vaccine efficacy. In other words, efficacy in preventing severe disease. What I would say to the parents is that this would not be any different. A rare event will never be able to enroll enough patients. What we depend on to be able to get our information as it relates to rare events is post-surveillance data. In other words, as time goes on, we will be able to tell if a safety flag had come up with a population of 2,000 in the trial that was done, that would be sufficient to shut it down. But the fact that there was no safety flag in that number of patients tells us that the benefits outweigh the risk. We're not talking about a high risk situation. But of course, time evolves and it is closely being watched. Should we note that there are flags coming up, then this is where our regulators step in to decide whether anything needs to change.
Thank you. Another question. You did say that we received good news that a third dose, a booster dose of the current messenger RNA vaccine may offer some protection, a better protection against Omicron. So with that in mind, what do you foresee to be the schedule for the 5 to 11s as they begin vaccination?
So the truth is, with the 5 to 11, I do not think that our schedule is going to change right now. We already are staggering the dose to 2 months. And what we know is that currently the third dose that is being recommended in adults is recommended at the 6-month mark. So I do not foresee a change in the immediate because we already have just gone 1 dose and we now have to go 2 months later, unless something dramatic changes. I think the key would be whether as data evolves regarding the Omicron and the vaccine performance, if we are finding that there is vaccine failure or poor performance, the question would be, is there a need for a vaccine to target? Not necessarily. So let's say even another variant emerges and that variant evades vaccine protection. But then the question that would emerge would be, can the vaccine producers come up with a vaccine that can address that new variant? But I don't foresee that we're changing anything right now with our schedule with the children. I think, one, we're waiting to see how things go with our children. We're getting data from the states and their experience, which is really good. And then when we give our second dose, we'll get even more data.
Right. And Michelle, it's clear also that Canada has adopted a 2-month interval between the 2 doses, which is not the same with our counterparts south of the border. And it seems that the data was generated in Canada to show that the 8-week interval was associated with a better immune response. What's your comment on that?
Yeah, so ironically, I think because it started off in Canada, maybe because of vaccine shortage, at the beginning we stretched doses because of vaccine shortage, but that allowed us to get an understanding of vaccine responses in that cohort. And as a result of that experience, the science group has decided that it would be best, or NACI has decided it would be best to stretch the doses to improve vaccine response. So I think they have the data, and based on the data, I think it's always good to be driven by data. And if there's evidence for something, then certainly we should do it. And I think it's going to be an interesting experiment because we have 2 countries, two different approaches, and we will see how that turns out in terms of whether it influences disease epidemiology or influences adverse events.
Right. I don't see any other questions, but we will press on since we have some time. Michelle, you did talk about the fact that the use of social media in this current dispensation we are in has allowed fast-moving misinformation to influence people. Before the COVID, had you sensed that kind of or resistance against vaccines was already showing itself in regular vaccinations?
So you are right. I have been in practice for quite a while, and I've come from practice in the developing world. and come to Canada. And I still think, having been in Canada since 2004, I have noticed a change in the parents who I've seen probably in the last 5 years. Younger parents, more entitled parents, parents who feel that they know how to do research, and the whole Google, social media is where they source their information, and that sourcing of information has so this actually preceded COVID-19 for sure. It's definitely in our area where we have a significant percentage of our parents who are not vaccinating their children in Southwest Ontario, where I work. I have seen an increase in number of parents who come in with their cell phone and showing me, and something on the Google that points to why they shouldn't get vaccinated. So this has been going on, but I think it culminated in the pandemic. And it culminated in the pandemic for multiple reasons. I think the merger of this being totally a new global event that totally impacted people in every area of their life as it relates to finances, jobs, everything, got some people really angry. And so it created an opportunity, that sort of mix, to be able to have, if people are angry with public health and the health advocates, then it gives the, if you then allow misinformation to be put on the internet and it's shared to angry people, it just escalates. The spread of the information escalates, and you don't have an opportunity, especially if you're not constantly reinforcing the message, then within the population that's reading the information, then it becomes a challenge. And on top of that, add to that lack of trust, add to that the racial tone and everything else that has happened in this pandemic, clashing with other pandemics, the racialized pandemic that took place over in the 2 years, that Black Lives Matter, etc. Everything has merged together to create a perfect storm.
Dr. Allen.
Well, thank you, Michelle, and thank you, Isaac. So, Michelle, I heard someone say, listen, I went to university, I got an undergraduate degree, I got a law degree after that, I got a PhD after that, and I've educated myself beyond that, and yet I'm not able to convince certain people who have less access to the education that I was able to access. Where did I go wrong? How do I reach those people? So what do you say to that? Where's the gap? Like, how do we convince people that I think that at a different place in terms of being able to understand the research and trust me, I can help you to interpret it. Is that, are we being elitist there?
I think it's hard to establish trust if it's a first-time connection. I think that type of person would best be served by a pre-existing relationship. So if you had a parent who's a lawyer who is getting their own information, hopefully they would have formed a bond with a family doctor or a pediatrician from before. So when they get that information, because of an established relationship and trust, it may be easier, but it's a difficult situation if you're meeting that person for the first time where they don't have a relationship with you. It's going to be a hard nut to crack.
And can I ask another question, Isaac? That's
sure, go ahead.
So with Omicron, you know, we've seen the emergence of a variant that is potentially more transmissible than Delta and other variants before that. And it likely emerged within the crucible of viral replication in the non-industrialized world. So my question, comment is, what would you say about efforts to bring about more equitable global distribution of vaccines to prevent the emergence of these types of variants and shutting viral replication down in Africa, Latin America, you know, Caribbean, wherever?
Definitely. I think this is exactly what had to happen for everybody to get their attention on the developing world again, to redirect. And it's not an easy fix because there are multiple layers to vaccine dissemination. It's not just vaccine availability. A huge part of it, I speak as a member of the Caribbean. I am shocked and disappointed with colleagues, healthcare workers who haven't done their own research or who are spreading misinformation. So it's one thing not to be convinced for your own self, but when you spread misinformation, and it comes from a healthcare worker, it's dangerous because it actually breaks down every sort of trust between the public and the healthcare team. And I think within the developing world, there is a large number of healthcare workers who have not bought into this and are also, or maybe a part of the misinformation. And I think this is going to be a huge challenge, not just to supply the vaccine. And I think it must be a priority. It must be seen as a priority that vaccines need to be supplied to the industrialized world. But we also need to put on our thinking caps to come up with strategies to overcome the various challenges that are preventing the vaccine, preventing, you know, vaccine equity, or it's not just equity, vaccine availability. So vaccine access. So there are access issues within countries. Even when the vaccine is sent, is it being distributed evenly and across in a fair manner? We know that there are so many issues that we face in the non-industrialized world, and I think it's time for us to look and analyze the various issues and then figure out how we can solve them. Yes, we need to get vaccines there, but we need to understand the other dynamics that are preventing or inhibiting the program.
Michelle, thanks for raising the issue that availability is not always equal to access. That in some places, even when it's available, if it's not accessible to people, then they will not be able to utilize it. Even here in Canada, that's why there were efforts to make sure that the racialized communities and people who had more difficulty moving around were able to receive their vaccines by taking the vaccines to them. And that has really made it possible to make it accessible to people. So thanks for reminding us that it's a complex issue, because I gather even in South Africa that although the vaccines are not as available compared to places like Canada, there's still a high level of hesitancy. And so, yes, there's a lot of work for us to do, both here and internationally, to promote vaccine acceptance.
Yes, for sure.
Wonderful. You want to give maybe your summary message, Michelle?
Yes. So in summary, I would like to say that our challenge as healthcare workers is to realize that the pandemic has been challenging for parents, and the now availability of the vaccine creates a dilemma in their mind and increases vaccine hesitancy, simply because there are multiple factors interplaying in their decision making and their understanding of the disease and the vaccine. And as healthcare workers, we need to be able to present the information in such a way that we can make it clear what the benefits are and who would most benefit. And then, of course, be transparent with whatever risks we know, and then allow the parent to be able to weigh the pros and cons and come up with their own decision, but supporting it right along the way.
Thank you. On that note, permit me to extend our sincere thanks to you, Michelle, for making the time, for giving us real insights into how to address vaccines and the questions that parents have about vaccinating their children. Let me remind you all to provide your evaluations of these sessions. They are very valuable to us as well, and it's part of the whole process of accreditation. So thank you very much, and we look forward to see you next week, when the focus is going to be myocarditis and pericarditis, the big elephant in the room. So let's participate next week, and we look forward to see you all. Have a good rest of the day. Many thanks.
Thank you, Isaac. Thank you, Dr. Allen.
Thank you so much. Bye-bye.